to do that yet. Hold on. Damn it. Hold on. I have to end this.
Hi, everyone. Welcome to our broadcast for Ethics Treatment Approaches for Special Education 619. My name is Taylor Broadwater, and my group members are Casey Stanton.
Hello.
Candace Earls.
Hi.
And Randy Hoekstra.
Hello.
Although applied behavioral analysis has a long history of developing evidence-based treatments that positively improve the maladaptive behaviors associated with individuals with autism, it continues to be considered unethical by some people with disabilities, advocates, and professionals. My group will discuss the pros and cons of these issues and develop a defensible argument to why ABA is or is not an ethical treatment approach. I'm now going to hand it over to Candace, who will begin as the pro stater, sharing her thoughts on how ABA is an ethical treatment approach. She will be followed by Caroline, who will present the rebuttal for this topic. Each member will be allotted
approach because behavioral analysts constantly ask themselves on a day-to-day basis, what is fair? Right. Am I qualified to administer this treatment? Any harm? Am I taking enough data? Am I interpreting it correctly? Would my client be better off without this treatment? Behavioral analysts use the core ethical principles in the code and guidelines to drive their ethical decision making on a day-to-day. Now I would like to transition into discussing each core ethical principle and how it relates to ethical decision making in ABA. Number one, behavioral analysts do no harm. They refrain from mischievous treatments and avoid harm through only practicing within their expertise. Number two, respecting autonomy. Behavioral analysts promote clients' independence and self-efficiency. Our main goal is to get the clients to deliver their own reinforcers instead of relying on the mediators. Number three, benefiting others. We have a checks and balance system to maintain services that aid in clients' best interests at all times. Number four, we are just, or being just. Treat the clients how we would like to be treated, and we abide by the golden rule. Number five, being faithful. We are dependable and reliable professionals. Our goal is to gain trust by our clients and as a whole field of ABA. Number six, according dignity. We want to voice the client's needs, especially for the ones that can't represent themselves. We allow the client this means that we express sympathy and concern during all of our treatments, and the primary focus is to do what matters most to our clients. Number eight, pursue excellence. We do this through staying current in our new developments and research and constantly reading key journal articles. We also meetings, and that's just to name a few. Number nine is accepting accountability. We provide all treatments and services to follow the BACB codes and guidelines. This is a good gateway to discuss the BACB codes and how they also pertain to ethical decision-making of ABA. The Behavioral Analyst Certification Board is a nonprofit organization that was established in 1998 to meet professional credentialing needs of RBT, BC, ABA, BCBAs, and BCBA-D to implement ethical ABA services. Now I want to just discuss each code and relate it back to the ethical principles and how we use them to promote the ethical basis of our services. 1.0, the code 1.0 relates to the responsibility, our responsibility to maintain high standards of behavior as a profession. 2.0 is the responsibility to operate in the best interest of our clients, and the client being the individual, parents, guardians, and organizational representative. 3.0 is assessing behaviors through behavioral analytic assessment techniques. 4.0 is we use a strict behavioral change program.
1 minute.
5.0, behavioral analysts must act as a supervisor and be responsible for behavioral plan. 6.0 is our ethical responsibility to profession of behavioral analysis, meaning to focus on the science of behavior change and not just the theory. 7.0 is our ethical responsibility to colleagues, meaning that we must be aware of treating others with care and compassion all the time. 8.0 is a pursuit of excellence, especially when addressing the public. And 9.0 is designed to conduct and report research in accordance to recognizable scientific competence and ethical research. 10.0 is to adhere to this code and all the rules to support the fact that ABA is ethical. Again, ABA is ethical because we always look to avoid the slippery slope of ethical dilemmas by abiding by principles and codes. And here's Caroline to address the con side.
Thank you. When considering components of ABA, there are some controversial practices within the field that draw some negative attention. I want to discuss a few practices that have been found to be not so autism friendly. One component of potentially damaging ABA practice that is an element of compliance. That is forcing a child to complete a certain behavior. Sometimes these behaviors are pretty simple, like touch head, touch arm, etc. This may be an issue when confirming desirable to the client. The BCBA may ask the child with autism to touch something they find repulsive or uncomfortable in hopes of desensitizing them to that thing. This process is known as systematic desensitization. For example, if a child is extremely afraid of dogs, a BCBA may expose that individual to a dog several times over the course of a few weeks to months. Some reports from adults with autism point out that this doesn't happen because sensory issues are a result of individuals' unique neurotype. In order to get rid of this sensitivity, you need to get rid of autism, which, as you know, is not possible. And for many people with autism and their families, this is not even desirable. So the idea of a desensitization is really more about faking it until you make it. Additionally, some BCBAs will attempt to eliminate or decrease non-harmful adaptive behaviors such as stereotypy because they are unusual or different than that of a neurotypical child. According to researchers, stimming is a form of self-regulation. People with autism typically feel awkward or uneasy around other individuals and use this behavior to find comfort. A woman with Asperger's states that this behavior is a shelter from the storm. It is known that behaviors tend to have a notion to make individuals with autism more normalized. This is where you hear about the idea of individuals with autism becoming robots in therapy such as ABA. There's also a prevalent effect known as low generalization. This is something that can be attributed to ABA's approach of learning in a controlled environment. When a learner is introduced and masters a new skill during discrete trial training, DTT time, there's a low prevalence of generalization for some clients, meaning those skills that an individual has been working on for a period of time, meaning months, weeks, however long, in a certain area may only be occurring in those areas. Therefore, this skill is not even significant. Generalization should be made before a learner has mastered a skill or target. Additionally, ABA is primarily done in a controlled environment where the professional is providing the antecedent and the consequence is already controlled for. The therapy is not accounting for the times where the client is not in this environment. Therefore, an uncontrolled environment such as schools or a home or an outing of such, the behaviors are not being carried over, which is really what we want to see in our therapy. Thank you.
All right. Our next topic is therapy methods with the ASD population. Randy will start as the constater for this topic, comparing alternative therapy methods. He will be followed by Casey Stanton, who will present the rebuttal and discuss successful ABA treatments in real life. Each member will have 5 minutes each to present their case.
Thank you. So as we all know, as I'm sure Casey is about to present, there are many times when ABA can be an effective treatment for children with autism spectrum disorder. Rather than try to dispute this, I would like to draw attention to a memo released in July of 2014 by the Centers of Medicare and Medicaid Services, which states, while much of the current national discussion focuses on one particular treatment modality called applied behavior analysis, there are other recognized and emerging treatment modalities for children with ASD. Those sentiments are reflected by Melody Musgrove, the director of the Department of Education Office for Special Education Services in 2015, when she stated, some individuals with Disability Act programs may be using ABA therapists exclusively without including or considering input from speech-language pathologists and other professionals who provide different types of specific therapies that may be appropriate for children with ASD. These quotes, I feel, do an effective job of highlighting the real ethical concern here. Not so much that ABA isn't effective, but rather if it gets utilized as a de facto treatment for all children with autism across the board, we are doing an injustice to the population that we serve by not providing an in-depth and objective analysis of the different types of treatment that are available and effective. So what is available and what is effective? Well, in 2005, the National Autism Center released Phase 1 of the National Standards Project and Phase 2 in 2015. Both of these were year-long or multi-year meta-analysis data-intensive programs which assessed studies which analyzed the effectiveness of different modalities of treatment in the ASD population, specifically under the age of 22. The results of this program found 14 established interventions that they deemed as confident in the effectiveness of having positive outcomes in the ASD population, as well as 18 treatment modalities that they deemed as emerging in effectivity. To clarify, the 18 in the emerging pool had some programs that showed that they had positive outcomes in the ASD population, but there was not the breadth of studies or data to leave them as an established intervention. Of those 14 established interventions, just to name a few, they include behavioral interventions, cognitive behavior interventions, peer training, parent training, pivotal response training, and comprehensive behavior interventions for young adults, which would also commonly be referred to as ABA. So, to highlight just a couple of those interventions that could also be used for ASD, and first being cognitive behavior therapy. Originally emerging in Phase 1 of the National Studies Project, it moved into an established intervention in Phase 2 with having 13 analyzed studies, and has been shown to reduce anxiety and depressive symptoms, particularly in ASD members in the higher end of the spectrum, as well as improving cognitive functions, emotional regulations, improved social awareness, social motivation, and social communication skills, as well as being shown as decreasing overall problem behaviors. The largest pool of articles in the second phase of the National Standards Project, out of the almost 400 articles were of the behavioral interventions, typically proceeding with antecedent and consequent interventions. These interventions boasted higher cognitive functions, motor skills, academic communications, and learning readiness, as well as play skills and self-regulation, while at the same time being shown to decrease problem behaviors as well as repetitive restrictive behaviors. Peer training is also another effective treatment for ASD, which has some draw to it as making friends with peers is all with ASD diagnosis. Peer training has been shown to increase learning readiness, communication skills, as well as interpersonal skills, while reducing restrictive repetitive behaviors in the ASD population. Parent training has also become an effective as well as popular method because it involves the parents. Sometimes, especially with ABA, it can be seen as being something that the parents have to stick to rather than part of the process that they get to be in their children the appropriate skills. Parent training has been shown to increase interpersonal and play skills, as well as decrease in general symptoms and problem behaviors, as well as restrictive and repetitive behaviors. Those are just 18 emerging behaviors. These include things like music therapy, as well as theory of mind training and functional communication training that in the future might be shown to be established rather than just emerging practices in treating ABA. All this is to say that there is a plethora and no shortage of effective interventions that may help and be beneficial to the ASD population, and they should be viewed in the totality rather than just singling out one treatment modality. Thank you.
All right, thank you, Randy. Our third topic of discussion is historical significance. Candace Earls will start off as our pro-stater.
Rebuttal.
Oh, yes, you have to do your rebuttal. Go ahead.
Although Randy highlighted some really interesting points in terms of what other alternative treatment methods can give the same results as ABA, I have found other articles that also propose the exact same results. In one specific study of real-life examples, there were 53 parents who were interviewed over 2 years of early intensive behavior interventions. And the results showed very similar findings to what Randy was stating with cognitive behavior therapy. In the visual that I will be explaining in just a moment, it does show that a significant portion of the parents had had revealed that their child had a lot of improvements in their personal lives, with peer play, with language, so on and so forth, over these 2 years of intensive treatment. So it does show that it's not only just with alternative treatment methods. This is also one of the big reasons why ABA is still extremely popular. Once my visual aid does pop up, I can show you some of the actual specific things that the parents did say about their child within this treatment. Communication skills was also one of the major ones, as well as improved communication skills and play skills. And I can say until the visual pops up. But essentially it's snippets of what the parents had to say once the 2 years had ended. Taylor, do you have any update on the visual?
I am getting it right now. Sorry.
Okay, perfect. So once this does pop up, you guys will be able to see clearly what specific things.
Do you see it?
Oh, God. Hold on. That was scary.
Can you guys see it now or not?
I'm still waiting for the PDF.
It's on my screen, and I shared the screen.
Minimize what you're looking at right now. Minimize Hangouts. It's probably in the background.
Can you see it now, guys?
No. All I see is like your favorites. Can you minimize Hangouts? Because you won't be able to see the PDF if Hangouts is in the foreground.
Okay. It is minimized now. Yeah.
No. How'd you pull it up before?
I don't know. I had it the same way. You can't see it?
No, I can't see anything.
Okay, well then.
Casey, were you able to pause?
No, this is live. I can't pause it.
Okay.
So this is just going to have to be included, unfortunately, because I need that visual.
So I think I have it. There you guys.
No, that's not it.
The computer's not working right now.
Oh my god.
She has it, right? Candace?
Hold on. I can... That's not it, though. That was the old one that I was getting. Oh my god. We're probably... I think we're going to have to restart this. This is going on for too long.
You guys, it's on my computer. How are you not seeing it? Because I can't see you guys now.
I don't see it. All I see is me.
Yeah.
What? Can you see me still?
No.
Okay, I'm gonna just continue the rest of it until it pops up. So another part of the case studies that I did found was 3 years of intensive ABA, a case study. This child was 2 years old when they started the program and only had a 3-word vocabulary. She had a very difficult time with communication. She also had a very hard time explaining exactly what she wanted, what she needed. Okay, there's my visual. Perfect. Okay, and essentially with this, with the child with the case study, after the intensive ABA, she was able, she pretty much had acquired enough skills where she was able to be in a normal classroom, and that was because she started at 2 years old with 3 years of intensive ABA. Back to my first example with the 53 parents. As you can see in my visual, these are the responses directly from the parents. With improved language and communication skills, 100% said that their language did improve drastically during the 2 years of intensive ABA. And as you go down, the scores do vary, but improved social skills was also very high, and practical benefits for the parents was also very high. So even though cognitive behavior therapies, they do also show similar high numbers, it is clear that this is where ABA does benefit the most and why it is one of the most popular and one of the most feasible options for children with autism. As you can tell from the first one with improved language and communication skills, one of the parents said to start with he had no language. You couldn't get him to do anything. Not only does he use language now, but he uses it in the right context and names things. He frequently asks you what you are doing, and there are times he talks more than the other kids around him. This shows that although in certain situations from a blind observer not understanding the context of the therapy itself, that it does work. It does have long-standing effects. And at the end of the day, these children are improving with the intensive therapy that they are receiving. Thank you.
All right, perfect. All right, so now we're going to move to our third topic, historical significance. Candace Earls will start off as our pro-stater, discuss the history of ABA. He will be followed by Randy, who will present the rebuttal. Each member will have 5 minutes to present their case.
Thanks, Taylor. I believe a lot of the misconceptions in reference to ABA have developed through the unfortunate history and the misunderstanding of behaviors and the maltreatment of clients. I know Caroline touched a little bit on this at the beginning of the debate, but now I just want to give a brief history of the development of ABA. It all started with behavioral modification in 1960. Behavioral modification was based around the theory that stated you do not need to know why the behavior occurs, you just need to know only how to manipulate the consequences. This theory was informal, destructive, and inappropriate due to the consequences of it was based on no code of ethics. It was just really unstructured. The structure really began through the development of 7 dimensions of ABA in the spring of 1968. Bear, Wolf, and Raisley published their article, Some Current Dimensions of applied behavioral analysis, which established fundamental characteristics of any good behavioral intervention. The 7 dimensions included in behavioral interventions are that they need to be effective, they need to be applied, behavioral, analytic, technological, be conceptual systems, and applied generality. These dimensions go all together, not separately, and are key when changing social significant behaviors to a meaningful degree. If not used together, the treatments can be compromised. These dimensions are what professional ABA programs use to develop quality services for clients, client-based techniques. Now I want to just address 2 examples of past cases where there was maltreatment and a misunderstanding of behaviors in general. The first one is the Sunland Miami scandal, which happened in 1972. These were acts under Dr. E, where behavior modification went wrong. It led to abusive acts of beatings, isolation, humiliation. This case led to review councils, including the Blue Ribbon Panel, and the developmental of the Journal of Applied Behavioral Analysis in 1968. The second one is Wyatt and Stickney, which happened in 1970 at Bryce State Hospital. Here there was a clear issue of staffing ratio, which led to layoffs, which also affected the accurate and better treatment of clients. And this led to the right of treatment, which is the legal right to behavioral interventions, and the mental health bar, which severely limits the involuntary commitment of people with mental illness to institutions. The importance of this is highlighting the use of least restrictive treatment. Now, ABA has more than 50 years of experience. ABA therapy was developed in the 1970s by psychologists Ivor Lovis and Robert Crowell at UCLA. The original approach was called discrete trial training, which we use today in ABA. Also, another important fact is that ABA is now endorsed by state and federal agencies, which lead to very strict educational requirements needed for ABA professionals. For example, in 2015, there was 15,160 with bachelor's degrees, 13,495 with masters, and 1,870 with doctorate degrees. This is important because even today there's a lot more ABA professionals because there's a steady rise in behavioral needs therapy, especially in the autism community. ABA is very evidence and science-based. This means that the behavioral analysts use science-based methodology proven to bring positive, meaningful change in individuals diagnosed with autism and intellectual disabilities. And Randy's going to hop on to do the rebuttal.
Thank you. So to start off, just giving a brief historical significance of an alternative measure, specifically cognitive behavior therapy. Cognitive behavior therapy intervention became more established due to the work of Dr. Aaron T. Beck in the 1960s. It has been a staple of the realm of psychology ever since. It boasts of being one of the most researched forms of intervention for certain disorders such as anxiety and depression. And the School of Cognitive Behavior Therapy boasts that over 1,000 articles have been written demonstrating its effectiveness. In addition to cognitive behavior therapy, we could also look at another popular intervention, behavioral intervention, which again moved to established treatment intervention in the 1950s and 60s. It was a branch off from the current realm of psychoanalytic approaches and moved to the forefront due to the work of people like Pavlov, Skinner, and Watson. The National Studies Project was the largest article with over 400 in both phase 1 and 2 combined. All this is to say that beyond ABA, there are firm bodies of evidence and historical bodies of evidence to suggest that these interventions are effective. Beyond that, other reasons why you might be tempted to use cognitive behavior therapy in addition over ABA, some considerations that you might take into consideration would be the time commitment, as ABA is often a very intensive program, going from 25 to 40 hours of intervention per week. Cognitive behavior therapy often involves 45 to 1-hour sessions, including parent session and homework that involve the parent rather than take them away and put the child in a special center, or doing ABA work with the therapist outside of parental involvement. Beyond that, cognitive behavior therapy highlights an educational component in describing feelings and emotions, whereas one of the complaints against ABA has historically been that it ignores the cognitive and emotional state of those involved in order to gain a set of compliance and instructional control. In addition to the historical significance of interventions such as CBT, it's also important to keep in mind that there are new technological advances coming that are bridging the gaps that have historically prevented people with the ASD population from getting access to interventions such as CBT. New technological inventions, such as those highlighted by Kasuku and Vanderberg-Davids in their study in 2017, which highlighted new robotic-enhanced cognitive behavior therapies interventions, which showed that such interventions can have bolstered impact on emotional regulation, as well as rational beliefs within the ASD population. Keep in mind that these approaches are becoming more and more accessible to the ASD population as these technological advances continue to grow. Furthers the evidence that they can be more common staples in the ASD intervention pool. Thank you.
All right. Candace and Randy went. So now we are going to walk into the Q&A section of this debate. We will start off by addressing the following question. How do ethical codes play a role in the decision to accept a child for ABA services versus another type of therapy? What ethical codes support the use of ABA as a treatment?
Ethical codes play a huge role when determining if the behavioral analyst's experience and expertise aligns with the needs of the clients. There might be another underlying cause of problem behaviors. Other medical issues may be playing a key role in lowering the success rate of services. Medical consultation of other services may be necessary when behavioral analysts see that for example, instances like feeding difficulties and psychological deficits may interfere with the continuation of ABA treatment. Code 2.01 and 3.02 state that if a behavioral analyst, the behavioral analyst's responsibility is to retrieve guidance, training, and education in areas they are not comfortable with, or refer clients to another type of therapy if too far out of the expertise range. I would now like to link with Casey to hear an example, a personal example from her fieldwork.
At my position as a behavior therapist, we had a client where the insurance company had initially diagnosed her with autism. It was soon realized after a few months of intensive ABA treatment that in fact the underlying issue was not autism. It was some sort of other type of psychological disorder, whether it be ADHD or anxiety, but it masked it as autism because of the escape behavior she was exhibiting. Other than that, she was a fully functional 5-year-old girl. Once this was determined, my work did the correct thing where they slowly phased out her hours after so many weeks, and then she was consequently removed from the program overall. This does show that insurance companies do make mistakes. But I don't believe this is autism specific. This could be in the realm of other psychological treatment centers as well, and other clinics around the United States.
Additionally, I would just like to add in, from my side of the argument, in some cases, parents have admitted that clinicians gave their child an autism diagnosis simply because that label would make services more readily available for them. So how can we continue to provide a service like ABA if it's accruing to insurance fraud? So I definitely think we're going to need to look at more like regulated practices and things that can help us out along the way.
All right, let's move to the second question. The question is, how would you help a family understand if ABA, 40 hours a week, was the best therapy choice for a child diagnosed with ASD?
I'm going to be starting off this answer to this question. According to the article, the relationship between early learning rates and treatment outcomes for children with autism receiving in-home ABA. The more hours a child receives, the more likely it is that they will be able to, as what my work calls, graduate from ABA services and be able to continue in a more normal environment indistinguishable from their peers. This article continues to say if a child receives at least 30 to 40 hours a week for 2 years, this is far more likely. They did notice that 50% of the children that were placed in intensive therapy at an early age for at least 2 years had higher IQs and were able to be involved in normal classrooms with children their own age with very minimal support. The other portion of that article showed less dramatic results with children that received 20 to 25 hours a week. This shows that the more intensive the therapy is for a longer period of time with more hours does display faster and more lasting results. Essentially what this means is the fact that if a child comes in at 2 or 3 years old and they receive full-time hours for ABA, if the insurance company allows that to happen, the child will flourish very, very quickly. The longer that the parents wait for the child to be involved with ABA, let's say they're 7 or 8 years old and they're in school and the most hours they can receive are 15, it's going to be it's going to take a lot longer for that child to catch up, and there's a higher likelihood that that won't happen at all.
Thank you. Yes, as for the rebuttal, as far as helping a parent family decide whether or not 40 hours of ABA would be a practical or beneficial to their child, I think that requires taking a contextual look, making sure that we're first and foremost making sure that the parents are informed as to what exactly they would be signing on for, the amounts of ABA, what would be required of them, as well as what it would mean to stick to a ABA behavior plan. As Carolyn was saying, oftentimes people who undergo ABA can later complain about the intensity of it, things like instructional control and making sure that the child does something when they're told to do it, to the point of physically prompting them through tears to comply with requests, can be a very intensive thing to go through. And so one of the things that we need to take into consideration is the parental stress levels and going along with behavioral interventions such as that. A 2007 article by Switchenberg and Poland suggests that intensive ABA programming can have a very adverse impact in parental stress levels. So if this is going to be a concern, for example, if the parents have co-occurring disorders, are prone to suffer due to heightened stress levels, it might be worth it to consider alternative options that may be less intensive. In addition to the parental concerns, you also have to take into account just pragmatic. It would take, if it's going to be able to be feasible to do 40 hours, the parent's availability, as well as the child's functioning levels. If they're on the higher or lower end of the spectrum that might have an impact on where the parents want to take their child for treatment, as well as the ethical concerns that might be involved with subjecting a child to some of the instructional control aspects of ABA. Beyond that, you would also want to take into consideration any sort of pre-existing comorbid disorders, things like anxiety or depression, which might be better suited towards interventions, geared more cognitive behavior interventions if the cognitive level of the child permits it. Thank you.
All right, and our last question. Are there kiddos that do not need 40 hours of ABA a week? How does one make that determination? Is it the VB map, parental needs, or school schedule?
In order to make this determination, there are several factors that are at play at once. The insurance company does their own assessment of the child. And first and foremost, that is basically the bread and butter of knowing what the max capacity the child will be at. If the insurance company determines that the child can only have 20 hours a week and the clinician opposes that, essentially what the clinician has to do is they have to wait until the child's next assessment, submit in their assessment to the insurance company, and hope that the insurance company raises that child's hours. Now, at the other end of that spectrum, if the child is at 40 hours, that is when the parents and also the center that the child is at, that is when hours can be determined if 40 hours can actually happen, or are there other barriers such as the center doesn't have enough therapists to handle those types of hours right now, or the child could be in school, or the parents may not have transportation for 5 days a week. So I do agree with Randy in the last question where he did state that there are several factors at play in determining the 40 hours that a child does receive, because there are several moving parts within that child's life to determine if those hours can actually fit their schedule, fit their lifestyle, and also if it's even reasonable for the center, the school, or the parents.
All right, great. I think we are done. Thank you guys for tuning in and watching our debates. This concludes our debate.